This conference will now be recorded.
Welcome in, everybody. In this lecture segment, we're going to be talking about multi-system trauma. Multi-system trauma with multiple trauma, we're looking at more than one injury. And then multi-system trauma, what we're looking at is one or more injuries that are going to affect more than one body system. So for example, a injury that the musculoskeletal system is compromised and the respiratory system is compromised, or the cardiovascular system is compromised. So these are significant injuries. We mentioned earlier the indications of trauma alerts. So this would be a trauma alert every single time. Big thing is critical decision making when we are dealing with our significant trauma patients. So we arrive on scene and we're determining patient priority and severity. So once we do our initial assessment, this should be automatic. Okay, is this a load and go situation, or is this an indication where we might have to stay on scene for a little bit and do a couple of different interventions prior to actually moving the patient? Now, I hate the load and go or the stay and play rationale that oftentimes we talked about, because it's not necessarily load and go because it's a significant trauma patient or a medical patient, because there might not be interventions that we can actually perform while we're in the back of an ambulance transporting. Might be significant injuries that need to be taken care of on scene prior to getting them into the ambulance in order to stabilize them for that transport from their specific location to that designated hospital. We always want to limit that scene time. We talk about the platinum 10 minutes and we talk about the golden hour. Platinum 10 minutes signifies that we should try and minimize our on-scene time to 10 minutes. But like I just mentioned, there are certain interventions that we may have to do on scene prior to transporting that patient, or else we're going to end up with a patient who's in cardiac arrest in the back of our ambulance. Next is picking the appropriate designated hospital. So within our area, remember, we have St. Luke's and we have St. Mary's in downtown Duluth. Now, St. Mary's is classified as a level 1 trauma center. So they are the only classified level 1 trauma center in the area. St. Luke's is classified as a level 2. St. Mary's Superior, I believe, is classified as a level 3. So when you do have that significant trauma patient, chances are the best hospital that they're going to be going to is going to be St. Mary's in Duluth. So next, when we're determining severity, psychological criteria, anatomical criteria, mechanism of injury, and then also special patients and considerations. So first, when we're looking at the psychological criteria, this is what we're referring to when we're looking at the GCS score. So our Glasgow Coma scale, remember, highest score you can get is a 15, lowest score you can get possible is a 3. Now, certain protocols, certain guidelines state that anybody with a GCS score below 12 or 11 will be considered a trauma alert patient. It all depends on your protocols. Then when we're looking at the anatomical locations, again, where are those injuries in relation to that patient's primary organs? So if we have a patient who's got severe trauma to their chest, that could be a multiple system trauma because it could compromise the cardiovascular system, the respiratory system, and also the musculoskeletal system. Or is it somebody who's got their legs pinned? Or we have the musculoskeletal, and then we also have the blood vessel system that's compromised. Next, when we're looking at this, think of the mechanism of injury. So when we see something like this, was that patient located in the driver's side compartment, where it looks like it's a little bit more stable as far as integrity of that vehicle? Or was that patient located in the passenger side, or we can see that significant indentation in the passenger side compartment area. And again, with that impedance at least 12 inches or at least 6 inches, I can't remember specifically, but that's going to be a high classification of that mechanism of injury. And then next we're looking at those special patients, special considerations. So with our geriatric patients, and we're going to talk about the geriatrics and the pediatrics and the infants, they don't compensate extremely well. They don't have great circulation in order to compensate for injuries like that. Other things too, oftentimes they will be taking blood thinners such as Coumadin or warfarin, our anticoagulants, our antiplatelets. Remember, anticoagulants are going to be the medications that delay the platelet aggravation, and then our antiplatelets are going to prevent those platelets from actually grouping together. Next, general principles. As far as C-spine stabilization, they should be determined almost immediately once we arrive on scene. So again, if you're referencing your skill sheets, you arrive on scene, you take your scene or BSI, your scene is safe, MOI, NOI, number of patients, any additional resources that we have, and do we need to take C-spine precautions based on that mechanism of injury. So again, that should be done within our general impression or our scene size up category. Suctioning the airway, always take good practice here. And again, when we have a multi-system trauma, oftentimes it's associated with a motor vehicle accident, a significant fall, what have you. Aggressive airway treatment is always going to be in relation to interventions that we're going to be performing. Inserting an airway adjunct, because oftentimes we'll be actually ventilating that patient. So whenever we're ventilating that patient, we do want to provide some type of airway adjunct, whether it's an OPA, NPA, or one of our advanced airways, such as our King or our eye gels. Keep in mind the contraindication for our nasal airways. If it's a suspected basilar skull fracture, that is a contraindication of the use of that tool. Next, chest seals. Remember our open sucking chest wound. Whenever we have an open injury to that thoracic cavity, we should be able to identify that and treat that immediately. Ventilating the patient, we're going to go through our normal algorithm as far as assisting ventilations. However, in some protocols and guidelines out there, they're going to be talking about hyperventilating the patient with suspected head injuries based on an increase in cranial pressure. Now, this is a really good segment to dive into within your textbook, because I could be talking about this for basically the next hour and a half for anatomy and pathophysiology. Whenever we're ventilating the patient, this is a go-to. We're always going to be administering at least 15 liters per minute. Control those bleeding. Now, tourniquet application, our pressure seals. Kevin does a really nice job in teaching that, so hopefully you guys got some good tips and tricks as far as stopping that bleeding. And then next is immobilizing that patient and then getting them ready for transport. So next we're going to talk about incident handling. So in scene safety, now this is going to be a very dynamic scene whenever we have something like this. You know, oftentimes we're going to be in the middle of a roadway, or we might be in the middle of the woods, what have you. These scenes do have the tendency to change very rapidly. And even when we have additional resources coming in, like pictured here, that helicopter coming in, that can cause a significant scene safety consideration. Next, ensure the airway. Perform any urgent or emergency moves as necessary. So if that car is on fire, if we can't make that scene safe, remember the difference between our urgent or emergent moves. Urgent, we're actually going to be stabilizing that C-spine. Emergency moves, we're going to be moving that patient without any type of C-spine precautions. I'm sure you guys have noticed doing your mock and practice patient care reports that there is a trauma score that gets calculated for you. But the definition of that trauma score is a system evaluating trauma patients according to a numerical rating system determined by the severity of that patient's trauma. So here we can see that revised trauma scale. It's based on our GCS, our blood pressure, our respiratory rate, and then it's going to give us our revised trauma score value. Now, this isn't commonly used as far as documentation and actually relaying this to the hospital, but as far as quality assurance and quality improvement, the hospital systems and the trauma symposium systems, they really utilize this in order to flag their QI and their QI systems, QA and QI systems. So let's dive into a case study here. This is our dispatch information. We're going to say that we're working up in Lake County, Minnesota. So you're dispatched to Beaver Bay for a one vehicle motor accident. For those of you who don't know where Beaver Bay is, it is located in between Two Harbors and Silver Bay. So we are looking at about a 45-minute transport time from Beaver Bay to the St. Mary's Hospital in Duluth. So dispatch time is 2:30 in the morning, and it's a warm spring night. So our environmental conditions are good. Our lighting, however, is not going to be good because we're looking at 2:30 in the morning. The only positive behind that is the traffic on that roadway is probably going to be pretty minimal at that hour of day. We arrive on scene, and with that dispatch information, we are notified that this individual has struck a tree. Again, it is a one vehicle versus tree accident. We have unknown patient condition with that dispatch information, and we have unknown number of patients. So at this point, we're en route, our pre-arrival information, so now we are getting updated with that dispatch information. Law enforcement advises you that you have one patient and they are trapped inside that vehicle. Patient is unresponsive at this point. Next, we arrive on scene, and this is what we have. We have one vehicle 15 feet off the road, and we have a front end collision with a tree. So think of our trauma kinetics, what happened to that patient once they struck that tree. As far as resources that we have on scene, we have law enforcement, great people to utilize blocking off that roadway and ensure that scene safety. We have a specialized rescue unit with Lake County Rescue, and we also have Silver Bay Fire Department on scene. So we have organizations that can do a great job as far as removing and extricating that patient from that vehicle. So here, take this picture in. This is the vehicle that we have. Significant front end damage to that vehicle. So think of how fast that individual was going. Now, our speed limits aren't going to give us the best indicator, but it does put us in that ballpark. So that roadway is 55 miles an hour. Our best guess is this individual is going 55 miles an hour and struck this tree. So we arrived to our patient. Again, they are unresponsive, driver's side of the vehicle. Windshield is spider webbed. So we talked about this. This means that they have actually collided with their head to that windshield. Airbags were deployed, but the patient didn't have any seatbelt on. So just based on this information, that mechanism of injury, this is an automatic C-spine stabilization incident. Now let's dive into our ABCs and our immediate life threats. So we have gurgling respirations, and they're at 4 times per minute. So breaking this down, first off, gurgling respirations, we know that there is an airway compromise, and this individual's airway needs to be suctioned. Next, 4 times per minute, we know this is low on the respiratory scale. Normal value is going to be in between 12 and 20. So with this information, that patient needs to have assisted ventilations right off the bat. Next, we're assessing circulation. So patient has a weak carotid pulse. So that means that the blood pressure oftentimes is going to be lower than normal. And when we assess that breathing too, we're also seeing paradoxical movement. So we have a flail chest segment. So we're kind of stuck at our ABCs at this point. So our airway needs to be taken care of immediately once we identify the gurgling respirations. Ventilations need to be assisted right off the bat because they're breathing at only 4 times per minute, and they have an immediate life threat with that paradoxical movement. This patient is also showing signs of shock with that weak carotid pulse. So with that, go into our treatment for shock. Oxygen therapy, keeping that patient warm and getting ready for immediate transport. So there we can see that spider web. So again, not much we can do with that, but that is a good indication of severe mechanism of injury. There we can see that flail chest segment on that patient. So now what's next? So first, providing those interventions that we mentioned in that previous slide. Next is getting that individual out of their vehicle and then into the ambulance, and this is going to be an immediate transport. However, based on that information, we should automatically be thinking of how can we get this patient from their location to the hospital faster? And that's where utilizing that helicopter is going to come into play for something like this. So if we hear that dispatch information, we know we're 45 minutes away from the hospital, immediately request air care for this incident. Especially we already have those resources on scene. We can either call in additional resources in order to set up that landing zone or punch one of the fire department members in order to set up that landing zone. All right, that does it for our multiple system trauma. Thanks, guys.